Steve.
Hi, my name's Steve. I'm a youth worker in Ealing, and my role is to help make sure the youth voice is heard.
Wonderful. Have I missed anybody out? No, good. Well, then we'll begin. Let me just give you a quick overview of this. Last year was a traumatic year in many ways. We had two pandemics, COVID-19 and its devastating impact on Black, Asian, and minority ethnic communities. Far too many disproportionate deaths of Black, Asian, and minority ethnic individuals, far too many getting seriously ill, and far too many catching it. And I think what it did was it exposed a lot of deep-seated inequalities. Not only exposed these fault lines, but also exacerbated them. And then along with that, we had the death of George Floyd and the Black Lives Matter protest. And I think this double pandemic caused a perfect storm in which many people came onto the streets demanding change, demanding answers. And the response from Ealing Council was to come to me and others and say, we need to bring good people together, strong people together, and look at these fault lines that have been exposed, and to come up with a set of recommendations that will, we hope, help transform the lives of people living in Ealing, transform their institutions, give hope to the people living there, and be a beacon of hope and transformation. And that's why we've asked you to come to this meeting. That's why we've come to lay bare and dissect and find solutions. We want to be real. We want to be ambitious. Above all, we want to bring the citizens of Ealing together for this momentous change. And so I'm asking you to bring all your brilliance, all your ideas, all your humility and humanity to this table for this journey. I want us to begin, if I may, Joanna S., to show a podcast of the youth commissioners. We've asked them to go out there and talk to some of the issues around health, and they have assisted. And I want us to have a look before I invite our very special guest, Professor Kevin Fenton, who is the Director of Public Health in London. You can't get a better person, you can't get a more, let me say, senior person in London, in this area, who has come to you today in Ealing to have a discussion about this issue. Joanna Summer, over to you.
So I think my colleague Tan should be able to upload the audio, which is, as you say, young people talking about health. Tan, are you there?
Joanna, I'm just going to try. Between Kofi and I, we're just going to give it a quick go to make sure we can upload it. So just bear with us for.
Thank you. No, we can't hear it, and there must be something else we need to
hear it, Tan. All the best laid plans, eh?
I can see it, but not.
Who's the tech?
I'm just going to try again. Just bear with me, please.
Okay. In the rehearsal, this went perfect, by the way. You should know that. can kind of hear something, but clearly not enough for us to grasp what's being said. All right, look.
Okay, I'm going to try again. All right.
One more try, Tan.
So I'm going to go. I click on. When I click on the. Oh. Hello.
Yep.
Yeah. So so when I go to share screen, I click on.
One
Yes,
last
talk
try,
me
Tan.
through it. Yeah. So I'm sharing my screen, but obviously there's no sound.
No, let's leave it, Tan. Let's leave it because people are waiting too long. Look, we'll put that podcast online along with the commission work. It's really important that we hear the young people.
Sophie, it's at the bottom of your screen. I saw it. It says share your computer audio. You're just sharing your screen. We won't hear if you only share your screen. It says share your computer audio. I saw it when you were doing it. So at the bottom now, at the bottom. Yeah.
Right, so I'm just looking into the. Sorry, I'm just listen to the lady. So she said, share my screen at the bottom of.
No, I think we're gonna have to leave it.
Right,
we're gonna have to leave it, Tan, because I don't want to lose time. And we've got. I'm hoping that we have Professor Kevin Fenton with us shortly. So we'll put that online to make sure that everybody can listen to what the young people have said. So I do apologize for these technical glitches on our first meeting, but this is the way things are in this new Zoom space. Do we have Professor Kevin Fenton in the wings?
I can't see him. I can't see him yet.
All right. Well, whilst you wait for Kevin, I'm going to introduce the issues that he will be talking about. As I said, that on a health spectrum, that COVID-19 has hit the minority ethnic communities extremely hard. In the first wave, do you remember the first wave? And we saw the black and brown faces that have been dying so disproportionately. 95% of the doctors that died in that first wave were from our communities. 35% of the care workers working in care homes were from Filipino communities, along with nurses, porters, security guards, bus drivers. And what we were seeing during that first wave is that all of these were overly exposed to COVID-19, not given the right protection. And what it said to a lot of people like myself was that, why are they overly exposed? Well, in many cases, they were working on low pay, 0-hour contracts, and had no other choice but to be in these overly exposed areas. Kevin Fenton and the public England brought out their first report back in May or June last year, and I've been speaking to Kevin recently, and what he said to me is that actually the data from last year is not much greater, is not significantly better, should I say. Instead of people of African and Caribbean descent being 4 times more likely to die from COVID-19, now, instead of it being African and Caribbean, it is Asian subcontinent, and then Caribbean and African second. So the difference of us dying in greater numbers has still not changed. Then to add another dynamic to this equation, of course, has been the hesitancy in which Black, Asian, and minority ethnic communities have been towards taking the vaccine. Now, we know some of that hesitancy comes from historical precedent. You know, the experimenting on Black and brown people in the USA, in Africa. And it was only a year ago when two French doctors talking about the COVID vaccine said, let's try the vaccine only on Africans first. So this is why there's been some hesitancy. And to exacerbate this issue of worry about what are the establishment doing to us, there's been some malicious individuals that are so in fear amongst our communities, telling us that we're going to have, if we're pregnant, it'll be a problem, that they're trying to put a chip into this vaccine, that it will change our DNA. And so myself and Professor Fenton have spent a long time, long hours, going around the country, speaking to whoever will listen, talking about the facts and why it's important for us to get these vaccination numbers higher. We've already been hit hard by it. Now, do we want to get hit harder again because we're afraid to take the only mechanism that will effectively keep us safe? So I'm hoping that, that Professor Fenton might be with us. And if he isn't, I'm going to call upon Dr. Mahini Palmer to come into the breach and help us with this conversation. Dr. Palmer, could I invite you to talk about those two elements? The first is about how this disease, in your opinion, has disproportionately affected our communities. And secondly, the hesitancy, the fear that many have on taking the vaccine. Could you speak to that somewhat, please, Dr. Palmer?
Thank you. Thank you very much for inviting me. So I think on the, as you have correctly said, what this pandemic in 2020 has shown is the inherent inequalities that exist within our society, and it has been completely exacerbated through this. We know that from the Black and Asian community, people work in jobs which were very exposed in the first part of the pandemic, whether they were in care settings, whether they were nurses, doctors, porters, cab drivers, bus drivers. And we didn't know enough about the disease. We didn't know enough about the way it spread at that time. We did have some confusing information on PPE, and people were disproportionately hurt. And we combine that with the prevalence of diabetes and hypertension within our communities, and we have a very difficult mix, and that absolutely showed it through in the first wave and also in the second wave. Though in the second wave, we have, when you look at the data, the equal number of a larger portion of white people have also been affected, because mainly we've got better at PPE, we've got better at infection control, we've got better at protecting our staff. On the vaccination front, Ealing has done really well compared to where we are. I mean, we are one of the most diverse boroughs, but we are still showing that where we've got the most hesitancy is among the Black community. We are still seeing that. And we've got 48.35% of people only vaccinated in the Black, while Asians it's 71 and white it's 79. So,
Dr. Palmer, why do you think that is?
I think you pointed out a couple of issues. I think there have been historical issues in the way drug trials and what happened in Pfizer and Nigeria. You know, there have been historical issues afoot, and that has not helped. I think what hasn't helped also is perhaps we have not spoken about vaccination in the language that people understand for the last 6, 7, 8, 9 months. Yeah. We've talked about, you know, opening of pubs, opening of schools, but we haven't talked about this in the way that people understand. And I think what we need to do is also speak to smaller groups of people, because a lot of this group of people may not be listening to your regular TV, radio channels, and therefore the way to address is to get into smaller groups, work with faith leaders, and get into those communities and actually take the vaccine to where people are.
One last question for you before I bring in Professor Kevin Fenton. When people come to you and they're hesitant about taking the vaccine, what do you say?
Well, I sit down, I know them, I sit down, I go through the evidence, I show where disproportionately it's been harmed, where people have been harmed, and I take them through it. And I would say 9 out of 10 times people have accepted, and I don't take the first no as an answer. We've got 3, 4, 5, we keep going at it because people recognize people's fear and apprehension.
Thank you very much. Please stay with us. I think we're going to come back to you again. I think we can now introduce our special guest for our first session, Professor Kevin Fenton. I want to give you a very warm welcome because I know you are in very popular demand over this past year. That COVID-19 has been on everybody's lips, and people have been looking for answers to some very difficult questions. I know today that you was on a platform with His Royal Highness Prince Charles talking about vaccine hesitancy. We did something the week before with Westminster Council. And in many ways, you've become a role model, a trusted figure. And we've got 2 key areas that we want to put to you, Professor Fenton. The first is this disease has massively impacted our communities, first wave and second wave. And if you could give some articulation to that. And then this more immediate problem that we've got too about hesitancy. And then I'm sure there'll be a number of questions. And I know you could speak about each one for about 3 hours, but if you can do some broad strokes, and but a very warm welcome to you, Professor Kevin Fenton, the Director of Public Health London. The floor is yours. But we need to unmute you first.
Yes. Thank you very much, Lord Willie, and good evening, everyone. And thank you so much for inviting me to speak this evening and to engage with you. So I'm going to really speak for just a few minutes to set the scene, because I think it's in the questions and in the discussion and the conversation that we will have the richness and authenticity of that we need, and that I think we all seek when it comes to addressing these very tough issues. So as you heard, I'm the Public Health Director for London, and I've been in this role for just under a year. I started on the 1st of April last year, just when we were at the peak of the epidemic in the city. And before that, I was the Director of Public Health for Southwark, and prior to that, a National Director for Public Health England. So I've been working both nationally, locally, and most recently regionally. Now, one of the things we've learned from this pandemic, as we've learned from many other infectious diseases, whether hepatitis or HIV or tuberculosis, that these infectious diseases are not randomly distributed in the population, but there are factors which are either personal characteristics, so your demographic characteristics, your health history, etc., or your behaviors, or the social conditions under which you live that can either increase or reduce your risk of acquiring the infection. So when the pandemic started last year, it was immediately obvious in the first wave, both with the high numbers of ethnic minority healthcare professionals who were dying from the disease, but also as the numbers began to increase, there was a clear concentration of the infection and severe disease, especially among minority communities who had multiple long-term conditions. So the work that we did last summer really highlighted some of the risks for severe disease and death, And this included a very strong association with increasing age, with deprivation. Black, Asian, and minority ethnic communities had a higher risk of severe disease and death than white Britons. There was also an association with sex, with male sex, putting you at higher risk of severe disease and death compared to females. So we saw these associations in the first wave. And what we also explored at that time in summer of last year were some of the factors which drove this. And you've heard this from the previous speaker today, factors such as predisposing social and economic disadvantage that placed communities at risk, just as when the pandemic hit. So communities that were less able to respond with the isolation, staying at home, working from home, were the ones that were more likely to be affected. Depending on the level of key worker exposure to the infection, either through caring professions like working in the healthcare system or in social care, those are the individuals who are more likely to acquire the infection. And of course, factors such as living in overcrowded, multi-generational households, not being able to isolate because you were having to go out every day to put food on the table and bring money in the home. Those were some of the risk factors that we found at that time. We also, at that time, spoke about the impact of those wider structural issues of discrimination, stigma, and racism. And we wanted to not only speak about this at the time when we had the Black Lives Matter movement, but because this was a real issue that the epidemic was forcing us to confront, that the long-standing structural inequalities within our communities were having a material impact on risk and outcomes of COVID. Now, I'm just going to finish by tying that all back to vaccines, because the inequalities that we've seen with vaccine hesitancy didn't start yesterday. They started before COVID. They were expressed in the first wave of the pandemic. We've seen inequalities in testing uptake, in contact tracing performance, and more recently with the vaccine. So as we have responded to this pandemic, the inequalities which have affected our communities are affecting every aspect of the response. So now with vaccines, we have a chance to not ask the question a few months down the line. We have the opportunity now to say, we know these inequalities are here, so let us design the delivery of the program upfront so we can help to minimize the impact of the inequalities moving forward. And that is why from the get-go, we've been pushing for better data, better understanding and engagement with communities on hesitancy, having the outreach and engagement, using materials which are multicultural, delivered by a variety of spokespeople, so that we can do that engagement upfront and not play catch up with the vaccine months later. And I'll end by saying that vaccine hesitancy is real and it has a material impact on the uptake of the vaccine in our communities. I've recently looked at the data for London today. Vaccine hesitancy in Black, African and Black Caribbean communities are greater than any other ethnic group. And we know that the uptake of the vaccine among Black, African and Caribbean groups are also significantly less than other groups. But there are other demographic characteristics. So deprivation, for example, if you're living in a poorer part of the city, you have lower uptake rates than in more affluent parts of the city. We know that there's a gender difference as well, difference between men and women. We know that white Europeans in the city are also not taking up the vaccine at the same rate as white British. And we know that there are strong associations with some types of religious denominations where the uptake is significantly lower or hesitancy is greater, for example, in some Pentecostal Christian communities compared to, for example, Orthodox Jewish and Church of England. So we have variations across a very diverse city, which I think is going to be important to also understand as we talk about hesitancy in the BME community. So I'll finish there, 5 minutes introduction. Hope that gives you a rounded view of how I see the world at this time. But I'm really interested now in the question.
Wonderful canter through very big issues. But as usual, Professor Fenton, with great clarity. I'm taking chair's prerogative and asking the first question. And that is, there are some that would say, when you talk about the social determinants that have impacted Black, Asian, and minority ethnic communities, they would say this, that yes, social determinants are true, but that's not just for Black, Asian, and minority groups, it's for all groups. So why are you talking about that? Mm-hmm. Second factor is they would also say, when you talk about, people like me talk about inequality in health in our communities, has exacerbated this situation. And they would say to me, how can you say that, Lord Woolley, when Black, Asian, and minority individuals living longer than white people? So that argument is thrown out the window. And the biggest killer of people today is cancer, and Black, Asian, and minority ethnic communities fare better than most. Both of these issues dismiss the disproportionalities that you and I talk about. What do you say to those?
Great question, and I just want to be absolutely clear. They will only dismiss the argument if we allow it to be dismissed. You cannot dismiss fact, data, and evidence on the basis of one, observation, which is not necessarily in keeping with the overall trend, right? So the fact that we may have one sunny day in winter doesn't make it the summer. And that's really important, because this is how misinformation spreads, that we have one opinion, and then we use that to discount the reality, the experience, and the evidence that comes from this. So very quickly to your 2 points. Number one, the social determinants affects everybody. And you've never heard me say that it's unique only to Black, Asian, and minority ethnic communities. Not at all. And that's why I was absolutely clear in saying that the work that we did in PHE has always looked at all of the domains of inequalities: gender, age group, ethnicity, and deprivation. And you'll always hear me speak about that, because those social determinants of health — do you have a job? Do you have access to good care? Do you have a family and support? Are you in a work environment that is supportive of you, etc.? Those cut across all communities. The difference is that there are structural factors, especially for Black, Asian, and minority ethnic community, rooted in historical precedent, that makes these social determinants operate at a higher and more severely impact level. So at a greater level among people who are not of white British ancestry.
Understood.
And that's what we're unpacking here. Thanks.
And the second part?
And the second part is around,
living longer.
For that statistic, I can give you many statistics about the higher prevalence of multiple long-term conditions among Black, Asian, and minority ethnic communities. I can give you data on poor control of these chronic conditions, which increases risk of a range of issues. So let's look at things as a whole. Yeah.
Thank you very much. I mean, the reason why I mentioned that is because, and I don't want to be partisan. It's not a partisan issue, but the government today are using those 2 facts to dismiss the disproportionality that's occurring to Black people. Look, I'm going to open it up. Please signal if you want to ask Professor Fenton a question. Please make it concise so we can get as many questions in as possible. Raise your hand so I can see, either physically or in the chat box, and we can begin the conversation. Who's first?
I think I can see Denise and Callum. I don't know if you can see them.
You can see better than me. So Denise, the floor is... And then
I don't have my hand up, but Callum does, so I'm going to let Callum go first.
Okay, all right.
Callum.
Thank you very much. And Professor Fenton, thank you very much for your presentations, and thanks for coming tonight. And I also kind of read your report that you kind of wrote last year, which I thought was really, really interesting. I had kind of 2, I mean, I have a bunch of questions for you, but I'll limit myself to 2 for now. The first, I kind of want to look back, and I want to want your assessment of how prepared you think that our kind of health institutions, be that Public Health England, whether that be our CCGs, whether that be our local authority public health teams, how prepared you think they were to kind of respond to the pandemic with a kind of obviously specific, the different ways that it would affect different communities. And then kind of looking forward, I wonder what role you think, or how how you think that different anchor institutions, and that not just, and I don't mean just our local health ones, but also whether that be our colleges and our schools, how you think they can work more effectively together to deliver better public health outcomes and develop more comprehensive public health strategies in the next few years, so that we are perhaps better prepared to counter any public health challenges.
Yeah. Great, thank you so much for that, Callum. And I'll again be brief to ensure we have as many questions coming in. But in terms of preparedness, this is a once in a multiple generational pandemic that we're going through. And no matter how much we had practice, we had used models on pandemic flu, we had lots of exercises that we did. In the middle of a pandemic, when you're dealing with a new infectious disease that is not behaving in the same way as what we had predicted, because we're using the flu models initially, right? And we were learning as we were trying to implement and control. I think all agencies had to act really quickly. And the scientific knowledge that we have now, a year later, is completely in a different place to where we were a year ago. So for me, there is that humility of understanding that this is not a normal, this is an extraordinary event that we've gone through. And I think very few countries who have not faced this previously would have had that experience. Now, the difference in China and some of the Southeast Asian communities is that they had the experience from SARS, and they perhaps saw what was happening before that we really appreciated the magnitude and the scale of it here in England. But that's, I think, going to be the cause for multiple inquiries in terms of understanding what lessons can be learned. To move to your second question on anchor institutions, we've been doing a lot of work with London partners on this, because we do want to ensure that the lessons of the pandemic are learned. And there are 4 key things that we work with and promote in terms of what anchor institutions should do. First is ensuring that policies are in place that really encourage and empower and incentivize anchor institutions to have plans and programs to address inequalities, both within their own workplace and well-being, as well as the communities that they serve. So it starts with good policy. Second, it's about the people, that anchor institutions have to take care of and lead their people in ways that promote inclusion, diversity, workplace well-being. Because if you don't care for your own staff, and if you're not tackling long ingrained stigma and discrimination, then how can you possibly want to do that in the communities you serve? Third, ensure that you have good programs. And anchor institutions need to hold themselves to account that you're not only developing and delivering programs that will meet everybody, but that you're designing your programs to minimize inequalities from the get-go. And then the final thing that we ask anchor institutions to do is to create new bonds and partnerships with the people that they're serving, with local communities. Too often over the last year, I've heard communities say, we don't trust this institution because of how we've been treated or because they're not engaging with us. And I think the pandemic has shown us that that engagement needs to be done at local level, at regional level, and national.
Great answers. And Mark, I hope that we're getting these down, because I want our NHS commissioning group to be aware of these, and maybe we'll call them those if we have time. I want to bring in now Sharmark from GOSAD. You've got a question for Professor Fenton.
I think Denise was ahead of me.
Sorry, Denise, I do apologize.
Okay, that's okay. Thank you. Thank you, Sharmark. Thank you, Professor Fenton, for again coming to visit us. I've got a question around what Dr. Palmer said about only 48% of Afro-Caribbean people have been vaccinated in the Ealing borough. What you started to answer it, but I think I'd like to have more information. What is the strategy going to be within Ealing? Or, I mean, maybe you can't talk about Ealing, but what is the strategy going to be to destigmatize having the vaccination and to get more people out there taking the vaccine? I know they're trying to do promotions on the TV with showing famous people, but does that work? Is that going to work? What are the strategies going to be?
Yeah. Great question, and I'm so glad you asked it, because this has been one of the things I've been really prioritizing and working on over the past 6 weeks, because I could see that as we have the vaccine, that this is the moment to get all communities taking it up so that they can benefit from us reducing disease and death. So 4 things which I think are important, Denise, if I may call you Denise, as we think about the work that needs to be done. Number 1 is better use of data. And that's really important because we need to understand where communities are not taking up the vaccine, which subgroups of communities aren't taking it up, and why. And that polling data, that research data, that vaccine delivery data is critical. Number 2, we need to do a much better job of outreach and mobilization. The work that we've done suggests that there are real questions that communities have, which range from the vaccine efficacy, the content of the vaccine, the safety, was it rushed? Does it contain materials that can harm us? Does it affect our DNA? And once we do the outreach and engagement and answer questions honestly, and really listen to people and what their concerns are, we know that helps. The third thing, which is important, which we're doing across London, is ensuring that we have a consistent drumbeat in terms of the communication, because if communities don't trust the information, then what you need to do is to ensure you're speaking truthfully and giving the facts, being consistent in how you do that, and to ensure that you're doing that over time and do it transparently. So that's the formula that I use to really help to deal with the trust issues. And that means that consistent engagement with Caribbean communities using Caribbean channels is going to be important. And then finally, to celebrate success, even although 52% of Black Caribbeans in Ealing may not yet have taken the vaccine, 48% of them have. And there's something for me about how do you get that 48% to tell their stories about going to the health service, about their experience, about how confident they now feel because they've had the vaccine, and to speak to others in the community. And that's where I think community mobilization really can help us with this. Thank you.
Great stuff. These questions are coming in now, or the hands are going up thick and fast. So I'm going to take 2 at a time. Mark and Nikki Flash. Please make your questions short, succinct, and then we can get as many in as possible. So Sharmak and Nikki, one after the other.
Sharmak Idiri. I'm going to do my presentation later on, but I'd like to say something. I've been a community activist for the last 20 years, from a young age.
You look too young.
Yeah, from a young age, and it pains me sometimes. I mean, I like what Professor Kevin is talking about, but the realities are different. You mentioned some of the policies that you like to see, for example, and unfortunately, I have a lot of things to share, how services are being designed without communities being included. Now there's a buzzword, which is a co-designing. It's an American kind of ideology, but unfortunately, it's been taken on by statutory organizations, and implementation of those kind of co-designing methodologies, again, is coming from the top. So the brief is already set, and then, so if I come to the issue around vaccination, so we're doing a research at the moment, and also, and I'll mention this in my presentation, we need to get away from the acronyms like BME, BMER, because I think it's not fair. And we put this in our report, which we published in September, that it kind of blurs the lines. So, for example, if you have a Syrian community who just started living in Ealing for the last 2 years, their issues are different from the Gujarati community, for example, who've been there for 50, 60 years. So for me, it kind of defeats the purpose. Now with vaccination hesitance, we are doing a project at the moment in Ealing, track and trace. So we've come out with very innovative ideas. So our organization, we work with the Nepalese community, the Somali community, the Syrian communities, all the different communities. And we think we've come up with a way that we can have these communities accept the vaccination, and we're implementing that. Now, people forget also there's an issue around mental health and hesitancy. We keep forgetting about that. People actually, we have people who, they're talking to us. We cannot tell people, you have to take it. We have to give them as much information as possible. But we can see how they struggle with that. And also we forget about the immunization for children, things like, measles and all that kind of stuff. So we have people, a lot of individuals from these communities who maybe English is not their first language. They've been receiving a lot of WhatsApp, conspiracy theory kind of stuff. But a lot of them, 1 in 4 BME, I'll use the word just for this argument. So 1 in 4 BME children have been found to have special needs. And a lot of these communities associate that with the immunization when this, the MMRs and all that kind of stuff. So there's already issues there. So it's not.
Mark, hold that thought. Hold that thought, because I've got many hands up. Professor Fenton, there's two points that I'm going to ask someone to come in. One is about health program designs, not incorporating the views of the community they're seeking to serve, and the unnuanced articulation of our communities that is often not judging like with like, and how can we get a better articulation with a kaleidoscope of minority groups. I want to just ask Nikki to come in, Nikki Flash, with hopefully a quick question, and then I'm going to put the 3 questions to Prof.
Thank you, Professor Fenton. So my question is, so we know that there are various priority groups as part of the vaccination program. Do you think that race should be a priority group?
There you go. That's what I like. That's what I like. See that short, succinct, to the point?
Ash.
Only because you're young, Sharmak, I gave you slack.
I'm only here until 6 p.m., so I'm going to be really quick. So, Nikki, thank you. I'll start with your question first. I think it was appropriate for age to be the primary consideration for the first few cohorts, because older age was the strongest determinant of the likelihood of having severe disease and death. So as you go above 70 years, the risk of dying from the infection was so much higher than any other population group. In addition, the focus on health and care workers was really important as well. Now, within that, the government's policy says that you can sort of promote, prioritize, encourage within that, which is exactly what we did for that first 4 cohorts. As we move into cohorts 5 and 6, where we have slightly younger people and then people who are clinically vulnerable, I suspect you're going to see now way more people from Black, Asian, and minority ethnic communities being invited. And that's why the mobilization is so important. Sharmark, agree with health program design. We have to move away from rhetoric into concrete actions with demonstrable and measurable impact. And so whatever we can do to help both the NHS and other systems as we transform to ensure that communities are center of what we're doing. I think that partnership with communities is critical. And yes, I agree with you about the importance of not lumping everyone together, understanding nuance and variation within community, and designing programs that really matter to local communities. It is harder work, but it pays off in the medium and long term. Thanks.
Okay, so we've got quick fire questions. I want to bring in Mark, Mahina, and I think that is it, which is great, because it means that we can get some good answers. And then I have a question for. I want a question for you, Professor Fenton, to put to Ealing Health Council, Ealing Council Health Department, about what you think they should be doing to make sure that they have greater representation, they are listening more, they are delivering better. So I want you to put a question to them, what they should be doing. So let me first ask Mark and Mohini. Excuse me if my pronunciation's wrong.
Professor Fenton, thank you so much for what you've said. We're all hoping, obviously, that vaccine acceptance increases, but have you projected or modelled the consequences of failure if we can't manage to get people to accept the vaccine? What would happen in our communities?
Great question.
And we're going to hear from Mohini as well.
Yes, we are. Yes.
Sorry, I'm Mohini Pamela, I'm a GP chair, Ealing CCJ. I wanted to respond. So we've just done a Health Watch survey in Northwest London, and the 2 big areas of reasons for hesitancies. One is testing, and it's trust. It comes back to trust. It's testing and not feeling that the information that the people have got is enough. So it's not fear. It's an issue of trust.
Great point.
Great. So Mohini, agree. Trust is really at the cornerstone of all of this, and you won't turn trust around in 2 weeks. And it does require a harder graft and much more deeper and meaningful engagement over time to help to change it. And as I said, the good news is when I look at the data, the gap between Black, African, and Caribbean communities, although it's pretty significant, is closing, and it's closing at a slower rate. So that's really good that we're seeing that gap close. And that links us then to Mark, your excellent question. You know, we don't have to we have really good examples from history and other vaccination and infectious disease programs where when you fail to control the infection in particular groups, what happens? So you can look, for example, at vaccinations for measles, mumps, and rubella, for chickenpox, all those childhood immunization vaccines. And when you have population subgroups, whether for religious reasons or for people who don't believe in vaccines and they hold their children back from being vaccinated, and you see outbreaks of disease occurring in these groups over time, and that has two impacts. One, it keeps the disease circulating in the population, but two, it results in outbreaks which disproportionately affect those communities which are not vaccinated. And even though we shouldn't be having people dying from childhood diseases, we do see this happening because we have various segments of the population, for whatever reason, who decide not to get vaccinated. So bringing that forward to COVID, my biggest fear is that the same communities who have been hard hit, who've taken the brunt of this pandemic, both for wave 1 and for wave 2, are not going to be able to take advantage of the most effective tool they have and we have to both protect ourselves and to end this pandemic. And therefore will be doubly disadvantaged moving forward. And that's my fear. And that's why the work and the conversations we have today are so critical. Finally, Lord Woolley, I'm not sure if I'm in a position to put anything to the council, given my role.
What I want you to do, I want you to put your inner activist hat on for a second and say to the council, look, if I was Simon Woolley and an activist, this is what I think that you ought to be focusing on. Indulge me if you can.
So I know you're going to accuse me of being a politician, but what I will say is this, that one of the questions I ask myself and I ask my team every day is, when the story is told of this pandemic, and when the questions are asked about how we recovered from this pandemic and history is written, how do you want to be judged as an organization? How do you want to be judged as a leader at this time? And what did you do to learn the lessons from the pandemic and to create a better and fairer future? And that's the question I ask myself every morning. I ask my team when I have team meetings. How are we going to be holding ourselves to account to make the difference that needs to be made? Professor
Fenton, I can see you running for mayor for London anytime soon. I better warn Sadiq Khan and Sean Bailey. As always, it is a great pleasure and an honor, really. I mean, I think you've owned that leadership space in this past year. Imagine coming into a job a year ago, this job, and dealing with this pandemic. But I think you've done it graciously and with leadership. If you don't mind, there may be other questions that we can write to you to answer, because this is an organic commission that is living and learning all the time. But I just want to thank you on behalf of everybody here this evening. Thank you for taking your time out today. You've earned your glass of wine or beer waiting for you. We have got another hour. We've got a few more minutes. We want to listen to Sean Mack's presentation, and then we're going to move on to housing. But if we can give Professor Fenton a round of applause. Thank you, good sir.
Thank you very much, everyone. Thank you for the work that you're doing. And please let me know the outcome of this really important commission and whatever we can do to support your work and your leadership in Public Health England and in the future. Do let us know. Wonderful. Take care, everyone, wonderful. And stay safe.
Thank you. Thank you very much. Wow. I told you, didn't I? I told you it was good, didn't I? And honest. And thank you for your great questions, really good questions. Let me say now, I want to bring in, where's our young man? Where's our young man, Sean Mack? We want to hear your presentation, brother. I know you wanted to grill the professor. That's why I gave you a little bit more time. But anyway, unmute yourself and the floor is now yours.
Can everybody hear me?
Yeah, you might need to get the microphone a little bit closer.
Oh, okay. Sorry, I'm using another laptop, so I hope you can hear me.
We can.
Yeah, Ifzal, thank you very much for helping me with the presentation. I'll try and be as quick as possible because I know time is of essence. I decided basically to do, so when the pandemic happened from our organization, which is called Golden Opportunity Skills and Development. So we closed our office on the 18th of March. And by that time we had about 375 active users of our services. So you can imagine, so we have the Nepalese community, we've got this Arab-speaking communities like Syrians, we have the Afghani community, Somali community. So they're doing different things like ESOL classes, employability project, advice work, and all of a sudden everything had to come to a stop. So we, working with Ealing together, which is a kind of the crisis platform for Ealing, we were able to engage with so many vulnerable people, but also our users. So I saw a lot of things are happening, but because there was a lot of issues, as I said, I've been a community activist for 20 years from a young age. Basically, I saw that inequalities from the beginning, that inequalities is going to be exposed. And then I decided to do this kind of research for GOSAD initially. But then I found out that we are working with a few other organizations. And, I decided to bring these organizations together. So these are BME-led organizations based in Ealing. And then I brought them all together to work together. So just quickly, so when the report was done, we lost about 25 people, but now it's over 50. So between all the organizations now over 50. Actually, we're talking about 75 beneficiaries from all these community organizations. And these groups, actually, they've been working in Ealing for more than 100 years. If you can go to the next slide, thank you. So these are the organizations. So the United Anglo-Caribbean Society was set up in 1971 in Ealing. You got the Ealing Somali Welfare and Cultural Association, was set up in 1990 in Ealing. Then the Tamil Community Center, which is I think about maybe 10 years old. And then you got the Came Women and Girls Development Association, which work mostly with West African communities. And then you got the Whole of Africa Disability and Elderly Association, which was set up roughly about 1999. Yeah, next slide, please. So a total of 342, I'm using the word BME. So BME residents were surveyed. And we used, because what happened at the time, and this actually has shown like across the country. So you have small organizations, for example, in communities, who you will find that normally they're not heard or they're not supported. And they were the first port of call for a lot of their users. And everybody was chipping in, everybody was supporting people who are distressed. Of course, this was a new thing. There's something else I was going to ask the professor, but it's about basically the information that comes from the government. So even at the beginning, there's a lot of information that we were trying to decipher to be able to speak to our communities. And I'll mention something very quickly. We have the Syrian community, for example. So they were the first to stop coming to face-to-face interventions, because they remembered, like back in their country, they unfortunately some of them they underwent chemical weapon, things that happened to them. So when they heard that this illness is in the air, they were the first community to be worried, and they're the first community again to stop coming to our center. Now, so we did a survey. Basically, we were able to be very innovative. So we're delivering food to people. We were, going out and about, supporting the community. So we used that opportunity. So we were able to survey 342, residents, and these are all from the different communities. Next slide, please, Ifzal. So the highest number of participants that took part in the program. Somebody mentioned about age early on. So there are, people who are aged between 46 years and 65. This was the kind of majority. So 300 participants indicated that COVID-19 had negatively affected them. And actually this is mentally, and around 250, which is a big number at the time from the survey, knew at least somebody who's passed away from COVID. And then 250 and more than 100 participants have indicated that they require mental health and well-being support. And also they indicated that they needed to understand up-to-date COVID-19 instructions. And as I said, as an organization, we've come up with very innovative ways of reaching to all these different communities, to demystify some of the stereotypes, some of the anti-vax information and things like that, but also at the same time to give them new information. Next slide, please. So what happened is, and I thought I'll use this presentation maybe to give some kind of recommendations. So these are the 5 recommendations that we came up with. And we wanted, and I think this commission is being set up. And I can say something quickly. Again, there's a kind of mistrust, and I just let this happen. Everybody know. When we talk to some of the organizations or some of the communities, they believe actually this commission is going to be a tick box exercise because the way, it was rushed, and also the way that people think maybe there's not enough representation. Those people are worried there won't be enough representation. But also when we looked at the policy document around this, we found that, there was some kind of information around, the finding of the commission necessarily won't be adapted by so the council will choose if or not to take on those recommendations. And again, we see history repeating, but this is something I can discuss with other people within the commission, no problem. Next slide, please.
Okay. Brother Sharmak,
yeah.
I need you to wrap up in 2 minutes because I need to draw this section to a close. And don't worry, we're going to take all your slides and worry them like a dog worries a bone. But for the moment, can I get you to round up, please, so we can close this section?
Okay, no problem. So the theme, so I chose the theme around health and social care. So we're asking for, effective communication by involving the BME organizations and individuals within Ealing to actually support any kind of development of services and things like that. Also, stuff around customer care. There's issues around, for example, GP appointments and issues around that. And mental health, we were able to identify 17 people who are not known to the system. These are people who are from the BME community, calling for health and social care providers to work closely with BME communities. Is quite important. The next slide, if I can just wrap up, I think that's the last one. So we're calling for proper scrutiny of the council's, housing, protocols and things like that. We have a lot of case studies around how housing has been a big issue. Also, we find that, if the commission is looking at inequalities, there's a lot of information within the council where we've raised complaints and other organizations across Ealing. Things have gone to the ombudsman. There's stuff around, discrimination, even racism. So the other thing I wanted to recommend to the commission is that to look at those cases within the council. There's a lot of information there that the council needs, the commission needs to dig out.
Sharmak,
I think I'll just finish with that, and hopefully.
Thank you very much, Sharmak. I want to say that on the housing one, we can come back to this in the next.
Yeah, sorry, I kind of jumped the gun there. Thank you.
That's okay. That's okay, brother. I want you to be enthusiastic.
That's all right.
Look, I want to introduce again Dr. Mahina if she hasn't gone. and also Councillor Ray. Are they still with us?
I'm still here, just trying to come off video. Yeah.
Well, two things really to you both. One, for taking time out to be with us during this. Really, we knew this would be the first and critical debate, and coming along and sharing your wisdom, I think is really wonderful. And I want to give the last thoughts to both of you, Councillor Ray and Dr. Palmer, about what you've heard, and particularly about what Professor Fenton said, that we have to look back and say, what was our role? How did we respond? What we need to do. Can I first ask you first, Dr. Palmer? Floor is yours.
So I think the health community responded very well, as Kevin said. You know, this is unprecedented times, and people just rolled up their sleeves and worked. And since right through the last 2 months, the GPs have been doing their vaccinations, working weekends. You know, it's just part of what we would do. What I think is really important is because it has also created some other inequalities in terms of access. So in Ealing, we have a system whereby every GP has to offer us X number of appointments per 1,000 patients. But because we've gone virtual, for people who are digitally excluded, we have created a problem. And I think we're recognizing that. And that compounds, as said, with people with mental health, with children and young people. And we're seeing that coming through now in terms of the needs for our mental health. But I think we have a long history in Ealing of addressing inequalities. We know the life expectancy gap going from east to west is 10 years. And we know the issues of premature mortality is to do with cancer, with diabetes, and with hypertension. And with cancer, I think your point was interesting, but we do know that we have some of the late diagnoses of cancer amongst the Afro-Caribbean Asian community. So it's not a good story, because actually we could improve outcomes if we pick people up early.
Thank you very much.
Yeah.
That's really incisive. I want to give the last word on this subject to Councillor Rab. Thank you for, I know you wanted to listen, but I don't want to miss this opportunity to get your words of wisdom. And I mean, look, it's a huge brief you've got, and I'm sure you've got broad shoulders, but I'd just like to get your thoughts about where you sit, the challenge that you've got.
So thank you for that, the opportunity to have a little say in this. I think it's fair to say that as a member of the BAME community myself, I recognise and really appreciate the inequalities which, you know, I've lived through myself. So I think in Ealing, we've worked very, very closely and collaboratively with the NHS in order to push boundaries, get things done effectively and quickly. But we recognise that there is a huge communication problem in terms of getting the facts out to the communities that are really difficult to reach. We are working on some further work on this, because the legacy that we'd like to leave is that we've reached the BAME community. We've reached as many of them as we possibly can, and we should be aiming for, you know, a target that's between 95% and 100. We'll never make 100, but that's what we want to do. And there are some plans in place to try and do this, and we hope that collaboratively we'll be able to do that. And I was actually going to contact Kevin Fenton myself on some of the work that we want to do, which I will do. So we're determined, we're working really hard, working collaboratively. There is a lot to do, and we intend to do that. So the will is definitely there. Right. And we're going to talk to the community in the languages that they understand and through the channels that will reach them.
Well, thank you very much for that. Lastly, I'm sorry that I miss you out, but I don't want to, so I'm making a play now to Maddie Got to Write. I know that you're a consultant in Public Health Ealing Council. And from where you are, I mean, look, it's an enormous challenge. Budgets are extremely tight. And yet there's an urgency to close these racial disparities that unless we have shoulders to the wheel and resources, they're going to grow. From what you've heard tonight, what say you?
Thank you so much, Simon. It's been a real pleasure to listen. I speak as a public health professional. I speak as a resident of Northwest London. I love living where I live because I am part of a widely diverse society and the huge benefit that brings. The Association of Directors of Public Health made a statement very recently in the last few days to say quite explicitly that racism is a public health issue. And they're our umbrella professional body in which my Director of Public Health, Anna Bryden, sits and works alongside Kevin regionally and wider our national colleagues. And this is a very kind of welcome statement from our professional body because these connections that Kevin describes between ethnicity, deprivation, housing, long-term conditions, occupational exposure, it's no coincidence. What's underlying that is racism. And I think what I'm hearing more and more, which is really welcome, is an appetite to call a spade, lay bare this reality, and also draw on the historical context that we know feeds into this. Now, I don't in any way hear it enough, and I think we've got a lot of work across the system to do to make sure that that's aired, but I personally want to be part of that movement. And there's a lot of responsibility needing to be taken by individuals working in a system for their system's historic wrongdoings that have fed into health inequalities across the country and Ealing. Lastly, my other kind of bugbear is that we in public health need to challenge our language use and our assumptions that underlie the work that we do, so that we are working, amongst our communities and not even with them as an arm, but within them in a way that's meaningful. So yeah, lots of work for us in the future, and would really look forward to working with you all more closely.
Thank you, Maddie, and Councillor Rabb and Dr. Palmer. Look, we could have had this session for 3 hours. It's such a rich vein of conversation. Here's the thing about it: the jewel in this conversation is that it's both honest, but also solution focused. How do we work better together? How do we not ignore? And Maddie Gupta's words, I mean, I'm going to remember that for some time. Racism is a public health issue. Racism damages your health. Fact. How do we solve it? So rather than wrestling with, is it or isn't it? No, it does. And how do we put it right? It's been a great first session. Wonderful questions from our commissioners and from outside, but we're going to pivot now to our second session. Where's Mark's there and Joanna? Do people need a 2-minute comfort break and then come straight back on with that? Could you do that straight away and then come back, please? I'm giving you 2 minutes just to, shake your arms and just stretch, go and get a glass of water, and then come straight back. We've only got until 7 o'clock, but please, this is not make a cup of tea and a sandwich. This is go get a glass of water or a glass of beer. It's that time if you so desire, and then come back for the second session. Thank you. Mark, Joanna, you there? Joanna, I told you time goes quick, didn't I?
Yes. We can use this 2 minutes. That's really helpful. We can either put Lynn's slides up, and Tan wants to do one last try on the sound.
Are we leaving the podcast out because it's a bit temperamental?
I think we know how to do it now, but I think we might not have enough time to put it up.
We'll go straight in. Lynn, thank you for your patience. I hope that
that's okay. We don't have to go through. I can shorten what I was going to say if you want to take the podcast.
No, we know that you've done a lot around this, so we want to give it its full time, and then
okay, that's fine. Thank you.
Bring in the others too. Maddie, thank you so much. I mean, I don't know whether you want to stay around, but
Saying
your final remarks. I mean, you know, for people to say that, it just gives us a North Star starting point that helps us work back from there, rather than having to, you know, with certain quarters, keep debating whether it's real or not. It's just tiring.
Yeah, no, I completely agree. I mean, not my words, can't take any credit for it, but and totally humbling to be part of this sort of conversation. So yeah, but I think it's a really important statement, and
it is. It is. It is. So don't be surprised if you see that in a press release when we got there. And who said it? Well, we know it's your body, not. So
no, it's already in many press releases, thankfully. Association of Directors of Public Health, but it's been picked up by the media, and I'm sure you'll see it again. Yeah.
Well, we're going to see it in Ealing, that's for sure, because people need to know the starting point and what we need to fix. And then I thought we had a very rich conversation with Professor Fenton and Dr. Palmer and all the kaleidoscope of questions, which is exactly what we hoped. What do you think, Mark?
Indeed, it was very, you know, it took it from all the different perspectives of provider, strategy, local challenges. Very interesting to hear those dynamics, and hopefully it will help us really focus on what we should be doing to take this agenda forward. You know, there's lots of operational things that can get in the way of actually having that laser focus on what do we do differently. How do we really make a difference, and where do we put our efforts? So I hope in response to Sharmark's, you know, I hear loud and clear community concerns, you know, around this. You know, I hope as commissioners, as independent people, you know, your report and your findings will be evidence-led. They will take and give clarity of direction. And coming back to Maddie's point, you know, the facts will speak for themselves, and there will be nowhere to hide or deny that. And, you know, and I have to say from the administration's perspective, I'm not the politician, but the instruction is loud and clear. You know, this isn't scrutiny. This isn't the council navel gazing at itself. This is the council asking, what do we do, and looking to the commission to help shape that future. So, very positive.
Well, he's definitely put down the gauntlet. Okay, I hope everybody's back. Had little comfort break, little stretch. I want to dive in now to our second topic, which is housing. And we're going to try the podcast. Over to you, Tan.
Sorry, you're going to try the podcast or the slides?
Yes, I've had my arm twisted.
That's fine. That's no problem at all.
Okay, Tan, over to you. You got one shot at this, Tan. Drum roll. Tan, I hope this is housing, not health. Talk to me, Tan.
Sorry, I'm just trying to find the link to the housing one. It's just in the last page. Sorry about that.
So we couldn't hear that one anyway, Tan, the health one.
Not?
So
okay.
Let's forget it. Let's just go straight to the slides, and we'll circulate them. Apologies.
Okay, that's okay. That's okay. We thought we'd give it a try. So can I now introduce Lynn Duval? She's head of housing at Ealing Council. Allocations and rough sleeping, very big issue. across London, and particularly in Ealing. Linda Val, the floor is yours.
Thank you so much. Thank you, Lord Woolley. And I mean, when we talk about housing, obviously there's a huge spectrum of people who own their own homes, right through to people in social housing, and people who have, obviously some people who have a degree of choice and autonomy, right the way through to people who are in housing crisis and have to be supported by the council. And there is a crisis in housing, as we know, and meeting needs and expectations are two very different sides of the same coin. I wanted to speak two different things, really, that I've looked at in advance of this meeting. One was to say something perhaps about rough sleepers and what's happened to them during the COVID-19 experience. And secondly, I have tabled a report which looks at equity in allocations, and I can say a little bit about that just to preface that, but that's probably something that could be looked at in more detail later on. But just to talk about rough sleepers and what's happened during the crisis and their immigration status. Next slide, Tan. There's a lot on this slide, but what happened was we were told in late March to bring everyone in. So the government's policy was bring everyone in, doesn't matter who they are, doesn't matter whether they've got recourse to public funds, bring them in from the streets. And 15,000 people were known to be either rough sleeping or known to be at risk of rough sleeping were brought in from the streets. And this was quite unprecedented, really, not something that's ever happened before. And there's a discussion there you can see between Stephen Timms and Luke Hall. Stephen Timms is DWP, Luke Hall is communities and local government, discussing this. And the legal position was sort of reiterated as no, local authorities, that it's the same situation. People with no recourse to public funds are not entitled to any help. But that local authorities could actually, at this point in time, because of the public health crisis, help them if they deemed fit. But it very much pushed the decision down to local authorities to decide whether or not to bring people in, or whether they were doing the right thing. Can we just move to the next slide? And what you can see here is across London, 40% of all those rough sleepers accommodated were ineligible for public assistance. And in Ealing, this was particularly pronounced, and a lot of you will be aware that in Southall, we have a lot of Indian nationals particularly. It was 60% in Ealing of people that had no recourse to public funds. 25% were EEA nationals without settled status, and the other 35% were non-EEA nationals and without immigration status. So obviously something that was impacting heavily on the figures in Ealing. Next one. And this gives you a little bit more of demographic information. You can see the age spread there. Actually overwhelmingly male, 90% are men, 10% are women, but what we know about women rough sleeping in Ealing is that a lot of them have very high support needs. And one of the things we're looking at is for a special scheme just for them, to try to assist them. 80% of the non-EEA nationals are Indian nationals, very strong links to the Southall area. A lot of them have been in the country for over 10 years, and they They have no regular status in the UK. A lot of them have been in cash in hand jobs and cash in hand accommodation, and they've lost those jobs as a result of COVID, and they lost the accommodation that they were in, and they've ended up on the streets. We already had many on the streets, but we have even more now. 80% of the EEA nationals are unemployed Polish nationals. Just looking at the ages there, obviously not as many young people as you may think. I think in certain parts of London there were a lot of young people coming onto the streets, but that wasn't the big cohort for us in Ealing, really. Really concentrated in that 35 to 44 age group. And a lot of these people, I mean, obviously, if you've been on the streets for a long time, you're not going to be in great health. And a lot of these cohorts included people that are clinically vulnerable or have really complex needs. A lot of people, as you may expect, if you're spending a lot of time on the streets, not so difficult to be involved in drugs, alcohol dependency, or to have mental health issues. All of those things, a very needy community. Can take the next one. This slide just sort of sets out the legal position really for us in local government. So at the moment, if people have no recourse to public funds, we can only act outside we have very limited kind of powers to assist them with public money. So, for example, we can, well, actually, we're coming on to it, I'm sorry, jumping the gun. By definition, individuals with no recourse can't claim any welfare benefits, so they can't get housing benefit. So it's very difficult for us to provide ongoing accommodation for them. So just move on to the next one, I think, rather than go into the detail there. Move on to the next slide. What we can practically do is we can give people basic shelter during a pandemic, as we have now. We can supply food to keep them going. And we can support them, help them to access drug, alcohol, health services during this time, or even when they're on the streets, we can certainly do that. And we can look at long-term accommodation, but not as a local authority. We can only do these things via a voluntary sector organisation. So what's happened in Redbridge is they're looking at a model where the voluntary sector is working with, in fact, it's the Salvation Army that are building a sort of a modular home scheme to try to accommodate these people because public money can't be spent on them. And obviously there are very few options. We can assist them through the council if they are very, very ill. But as a condition of that, adult social care, if they accept a referral of one of these people, then they will inform the Home Office. And that's very often a very big disincentive from anybody seeking help via that route. And we have had people with AIDS, we've had people with cancer, you know, terribly sick people that we've tried to refer through those routes, and some people still aren't keen if they know that they're going to be reported to the Home Office. The clinical commissioning groups are able to deal with health issues. But in terms of both of those things, the housing costs aren't necessarily covered. So that means the council has to cover those costs. And EEA nationals too can actually be accommodated at the expense of the council. And also, obviously, we can assist them to reconnect to their home country. But that's actually incredibly difficult when people don't have any documentation, for example. They've been here 10 years and it's very, very difficult to get any information to actually help them. So that's that. I think perhaps we can finish the slides there. I think that's the last slide. I was just going to say a little bit about the other issue, unless you want to ask questions on the rough sleeping elements.
No, well, hold that thought for a moment, because I mean, you know, it's a clear topic that we need to discuss, I'm going to ask you one question and then bring in Mick Savio. Is that correct pronunciation of your names? Mick?
It can be pronounced very different ways, so don't worry about it.
Well, let's try and get the right way. You tell me and let me listen.
Sub-ears is often the way it's pronounced.
Thanks very much. So for both of you, really, but I guess first to you, Lynn, that you've talked about the most vulnerable in this house, and it's heartbreaking. There's no other way of articulating this. And then there's another cohort of people that we don't have time to delve into in great detail, but those that are in poor housing.
Mm-hmm.
And having problems paying rent or need social housing. Could you give us a broad brush on how that's looking and what your challenge is there too? And Mick, if you could come in afterwards on that too. First, Lynn.
Yeah, I could say I can speak about temporary accommodation, and that's a sort of a mixed bag, because of course, from a homelessness point of view, let's take it from a homelessness point of view, because those are my clients. Of course, there's been an eviction ban throughout the COVID crisis. And what that's meant is that a lot of people that would have become homeless haven't become homeless. Of course, what we know is that at some stage they will be evicted, probably, from their accommodation if we can't prevent them being evicted by negotiating with their landlord or trying to get them assistance with any arrears, that sort of thing. But the other very positive thing that's happened is that the government has actually increased the level of what we call local housing allowance, which is the maximum amount of rent that can be covered by housing benefit. So it actually means that whereas before COVID, only 5% of properties in Ealing were affordable to anyone on benefits, it's actually 30% now because of this adjustment in housing benefit. So there's been some kind of positives, surprising positives maybe.
How long will that last, that adjustment?
Well, interesting, because definitely for the next year, it's going to still be kept at what they call 30th percentile, so that 30% of rents are affordable. But then, of course, we might have a freeze the year, we really don't know what's going to happen in future. But certainly for the next year, from April of this year, for the next year, right, that will continue.
Let me just bring in Mick, and then I'm going to open it up to the floor. Mick, you've pretty much got mission impossible. You've got a finite budget and a huge housing crisis, both with homelessness and deprivation and poor housing. Tell me what you're wrestling with on a day-to-day basis. What keeps you awake at night?
All of the above. It is a massive challenge. Ealing as a borough has just 17.5% social housing. The needs, I think, analysis looks at it saying that 36% of housing should be affordable. So we've got a big gap to make and meet towards. But that's a challenge nationally. It's not just an Ealing thing, it's a countrywide thing. Our whole way our country has changed over the last 30, 40 years has made differences. I'm not going to go into political side of things, so I don't think that's the key issue here. I think it's looking at the reality. Even if we take, for example, the thousands of people that we have over 10,000 on our waiting list, and you look at the lets that we made last year were, I think, close to 800. So there's a real challenge in getting affordable housing out there and getting housing out there. In terms of the challenge, I mean, homelessness, prevention is the key there, and you need a whole system response. The talk about benefits, work and early support, basically making sure that people get to the council early and trying to prevent them, because the cost of housing someone is much, much more expensive than the cost of keeping them where they are. And if there's a way we can try and help and assist on that, that's key. So you need a whole system response there. You've also got, I think, landlords. We have landlord regulation in parts of the borough, and that makes a difference. If you look at things like the point that Lynn made about the ban on evictions, where you've got no fault evictions, where people can just say, I don't like you today, so I want you to leave after your tenancy's gone. Not having that anymore makes a real difference. And I think landlords need to show empathy to their actual tenants, just not look at them as a cash cow. And there's stuff that we can do as a council that can help them that. But you also need individual responsibility. We've got to try and do as much as we can together to try and work that out and see how things are. But yeah, it's a
last question before I open it up. How are you on building a social and affordable housing in the borough?
Well, we have a target of 2,500 homes to build over this term. We will hit that target. These are generally affordable homes that are set at 30% of the overall level, but there's more to do. We're setting up a registered landlord called Broadway Living, registered provider, to help us deliver those. We've got massive work going on. We've got a significant loan from the local council. We've got lots of money from Sadiq. We really need to build more homes because that's what people need in the borough going forward. But there's a real challenge still to get the ground broken. Commissioners,
thank you both, Lynn and Mick. The floor is yours. Put your hands up so I can see. I can see Denise straight away. I'm sure Shamak may want to come in again on this one. We've got just under 20 minutes. Let's have some quick fire questions.
I'm going to try to be quick, Simon.
Shoot, Denise, the floor is yours.
Okay, so I've got a couple of things. So really nice to hear that the homeless people have been housed, and I know it's been happening because I went to the Grand Canal pub to drop some bedding for the homeless people that normally live there, and there was nobody there, so it's all been cleared. But my question then is, how long will they be housed for?
Hold that thought.
Okay, all right. And then my second one is, I definitely agree with Nick about prevention. Now, Ealing Council has spent a lot of money on the Manor House and the cafe in Southall. Why have they not supported those homeless people in being retrained in something? So I know you've been working with West London College. We've got some other people in there now who are based in Greenwich who are doing work, but that place has still not been opened. Nothing's happened with it. Ealing Council have had graduation ceremonies there. West London College have held a couple of events there as well. But that is a prime place where people could be in. And I know we're not doing training at the moment, but that is a prime place where people could be being trained to do something so that they could become social economic citizens and look after themselves. And I think 30% is not enough to have social housing. I think that number needs to be increased.
Thank you, Denise, and thank you for those short questions. Please take them down, Mick and Lynn. I'm going to come to you in a second, but I also want to come to Edmund. Edmund Akiju. Edmund, the floor is yours.
Thank you very much, Chair. I just want to ask Ealing Council specific experience in homelessness and people of ethnic minorities. What specific policies or steps are being taken to help people in this category against the background of the language problems that they have? So, for example, most of council services are being moved online. And we know with issues around digital poverty, around language, people of this particular background are going to suffer, or they would be disproportionately more hampered than people who have those who don't have such characteristics. So what particular findings have you or policy design have you put in place to help people of this particular category?
That's a great question, Edmund. If you're homeless, how are you going to digitally respond to access these services? Lynn, then Mick.
Okay. First of all, perhaps I could take the question about how long for are these people going to be housed? Absolutely, Denise. What we just to say that, so over the period, we've had about 350 people coming in under the Everyone In policy. And of that 350, around about 150, I haven't got the exact figures, but something like 150 have been permanently resettled somewhere. So they've either gone into supported housing or they've gone into a private sector tenancy, very often with support as well. The difficulty we have is that we have a lot of people that have been on the streets particularly have very high support needs. They're not ready to go into their own accommodation, and we don't have enough supported accommodation. So finding that accommodation is a problem, but we're working on it and we're trying to get more schemes off the ground. The big issue is that so many of them have no recourse to public funds. So we've got to bear in mind, we've got 135 people that are still in our accommodation, but there's no positive outcome for them because we can't afford to put them in. You know, we would be, if we were to put keep 135 people in accommodation, that would cost the council £25,500 a week. You know, and we haven't got it, unfortunately. So unless there's a change in the law or unless we could find a voluntary sector solution, we're really stuck, and it's not a good thing at all. Denise, I think your other point was 30th percentile isn't enough. 30% of private rented sector properties being available is not enough. I agree. I mean, it used to be it used to be pitched at 50%, so 50% was affordable. No, 30% isn't. But then we are trying to produce ourselves to try to counter these issues, our own affordable accommodation. As Councillor Sabius was talking about, you know, the 7,500 affordable homes, you know, not social housing necessarily all of them, but some of them, you know, at least affordable to people that are dependent on benefits.
And Edmund's question? Mick, do you want to pick that one up? Edmund, repeat the question for us quickly, please.
So it's in terms of the access and the digital divide. Yeah, there's always more work to do. We present a lot of information in different languages and different leaflets. We've got the customer service centre where people can present themselves out, although obviously under COVID times there are slight difficulties around that in terms of we're going through. But we try our best to try and engage as well as possible and to work as well as possible. But there is always more that we can do. So it's really important that we hear those kind of messages and try and understand the way to take that forward.
Okay, I've got three other questioners that want to ask questions. Nikki, Mark, and Adele. Nikki and Mark first, please. Nikki.
Okay, thank you. I think this is Lynn. So is it mandatory for undocumented individuals to be reported to the Home Office, or are they given an ultimatum or an option of getting help with establishing a legal status?
Yeah, it's not mandatory. It's our policy, and certainly the policy of our outreach team, not to give any information to the Home Office whatsoever. We would never get involved in any of that. We would never force anybody, well, we would never put any pressure on anybody to even to go for a resettlement, you know, package unless they've really felt comfortable with it. We do have immigration advisors who don't need to actually have any kind of, you know, who can discuss a person's claim with them, advise them of their rights, and certainly they wouldn't be giving any information to the Home Office.
Thank you. Mark and Adele, let's take two at a time, please. Mark Paulson.
Thanks so much, Lynn, for your honest appraisal. Given that we're talking about structural inequality, do you think it would be possible for Ealing to become a sanctuary borough for undocumented nationals? Could we then look at policy changes in terms of designating funds to deal with the fact that we have so many, specifically Indian nationals here in Southall who are on the streets? Otherwise, what's the solution? We can't just rely upon voluntary sector giving.
I know it's a really tricky one, but at the moment the situation is, in a way, we are a sanctuary, I have to say, for a lot of people. And our voluntary sector have been absolutely amazing. They feed people on a daily basis, and they support people and have been supporting people for years in Southall. Unfortunately, COVID has made it impossible for them to give a lot of the services that they gave before. The government have been absolutely clear in saying that they will not provide funds for people with no recourse to public funds. So we have to dress it up a little bit, and we have to say things like, well, we want money for people that are clinically vulnerable, for example. We don't call them people with no recourse to public funds. And we've got away with it so far. And we have managed to get some leverage in, some funding. My own feeling is that I do think there could be a realistic voluntary sector solution. I think the council could help, perhaps with a bit of land, for example, perhaps a meanwhile site, that a 10-year site, maybe, something like that, if we could identify something.
Well,
and we can help with crowdfunding, for example. One of the things we're doing is we're using an organisation called Beam, who are actually working with a lot of individual rough sleepers, trying to raise funds so that they can get into education, get into employment, get into work, and have the basic tools in order to do that. And they could help with crowdfunding. Thank you
for that.
Sorry
to push us with time. I mean, for me, again, it's heartbreaking that you've got to do things surreptitiously to be decent to the most vulnerable in our society. I mean, it's and if you were advertised Ealing as a beacon in that way, then you'd get many other London homelessness people and others coming to your borough that would make it perhaps not unsustainable. But I do think we may need a way of making sure that no one's left behind. I want 3 other people to do quick fire questions, and then I'm going to try and round this up in time, because I know you've got children to feed and yourselves to feed, and they are Councillor Joanna Kamadou, Adele and Sharmak. So very concise questions and then very concise answers, and then we're going to round things up. So Adele, in this order, Joanna and Sharmak.
Well, mine's just really a comment in response to Edmund's question. There is a project that's being rolled out from the council, and it's a digital inclusion project. I know 2 of my colleagues that have just presented to communications on it, Neelam and Lou, and I've actually directed them to Tan and Joanna on this particular issue around digital inclusion and people that might not be online or able to do not have that educational background to engage. So
thank you very much for that. You've frozen, Adele, so I'm going to move us on to who was next on my list. Yes.
I think it was me, Simon. Thank you very much. Lynn, just picking up on a point in the report Sharmak has shared in the chat, and also an issue that comes up in casework for myself and other councillors is around perceived inequality with the allocations policy. So we're talking about structural inequality, and this is a concern that comes up time and again from residents about how long they've been on waiting lists, about being offered accommodation that they feel isn't adequate, might result in overcrowding for families. Can you just speak to that, please?
Great. Hold that
Yes.
thought. Let me just get Sharmak on the last one, and then you can answer those 2. Sharmak.
Hi. First of all, I need to apologize because I could be the only person in this meeting who is not a commissioner or from the council.
Doesn't matter. The floor is yours.
Yeah. So basically, we've identified a lot of structural inequalities within Ealing Council in terms of housing. And Lynn, I've got a question for you. The question is, does the council have, a tenancy strategy at the moment? And I have a reason why I'm asking that question.
Sorry, can you say again? Tenancy
strategy.
A tenancy strategy.
And what does that mean, Sharmak? Why would you want that?
So basically, and this is why I think with this commission, I think there's more that needs to be looked at, housing and other things. So basically, 3 BME girls, their father died from COVID, and they wanted to succeed the property. This was not made possible by the council. We had to intervene as an organization. They could have been made homeless. And there is a equality, I mean, there is the Locality Act 2011, which actually specifies the council must have a tenancy strategy. So basically the council made a decision not to help the family succeed the property without having a tenancy strategy. And without a tenancy strategy, you cannot have a homeless strategy. So for us, we see a lot of, why inequalities happen. So that's just the reason.
Sharmak, got it. So
I think the key thing I can jump in and say is that we do have a tenancy strategy. It does outline what the rules of succession are. It is under review. We will continue to look through the details on that one. So again, I think it's really, really important that you're feeding this information into us, and that will really, really help us. But it is something that we have taken on board, and that will feed across all of them. Joe's point, yeah, it's probably that was a little bit one that Lynn might want to jump in on as well. But I kind of am on both sides of the coin, because I represent the South Acton estate, and the number of queries and questions I get about homelessness issues, about housing issues, about overcrowding, about the challenges. A lot of it relates back to the point I made earlier about what we have available to us and what we're trying to get out there. We really try to do our best as a council, but there is so much more we can do. And by learning where we haven't got it right or where we could do it better, I think that's really, really incisive and really helpful. So the more cases we can get, probably is beneficial.
Thank you, Lynn. Last words to you.
Yes, absolutely. There are massive waiting lists. As we said, the supply of council housing, social housing is very small. The demand is very, very high. I mean, I hope that the report, what we tried to do in the report is to demonstrate that actually, in terms of the protected groups, things are pretty, we're pretty well allocating, it looks as though things are reasonably fair. But what happens is we have an allocations policy, and that determines how much priority people have within our scheme. And we allocate according to that priority. In fact, we have something called a choice-based housing system, which means that people bid for accommodation, the accommodation is advertised, people bid for the accommodation, and the person with the highest priority under the scheme is successful in getting that accommodation. Every so often we might do an exercise like we have with this report, where we look and see who's actually getting the accommodation and which group they're from, and whether or not they are representative of the people that are actually waiting.
Thank you for that, Lynn, and thank you for all those that have contributed and all those that have supported this first commission hearing on two very big subjects. And we've laid a lot there, and we will take more evidence on these as we go along before we make any recommendations. But clearly, both on health and housing, we'll have to make some recommendations, because the issues are that are very, very telling and urgent. And of course, we understand as a commission that there's no magic wand, there's no money tree, but within what we think could change, we're going to make their recommendations. And we're not going to be held back by any party politics or anything else. That's what we're here to do. That's the mandate that we've got. I found this first session really instructive. And I knew that as commissioners, that you would bring your passion and insight, knowledge, on the ground knowledge to bear. So I found it really very, very helpful. Thank you to the counsellors and the medical experts that have taken time out. I'm sure this conversation is going to cascade in the borough, and Mark, I hope that we can pull it together. So when we have our wash-up sessions, if you like, about what rises to the top in terms of our priorities, we can take a broad look at these things. I'm sure that you're all very tired. Commissioners, get used to it. We've got many more of these to come. This is what you're here for, to change people's lives, policies, the institutions. So I just want to thank you all. Thank you for the officers, the contributors, to the people of Ealing that have sent in papers and questions, and my wonderful 18 commissioners. It is 18:59. You see, we're finished bang on time. Have a wonderful evening. See you for the next hearing, which is when? Joanna Summer, when's our next hearing?
It's March the 18th. So exactly
March the
4
18th.
weeks from
so
now.
We've got lots of preparation until then. We may speak to the commissioners about making sure that we're speaking to the right people before we meet. Yep. Before we meet then. So again, thank you all. Can I thank my vice chair, Councillor Joanna? I'm going to give the last word to you.
It's a very big thank you to all the commissioners, everyone who's come to speak today and really be part of this analysis of inequalities in the borough. I think it's been a very frank discussion. I think there have been some really challenging points raised. And the final point I would like to say is that this is an opportunity now for the commissioners to be the voice of those who feel that they've otherwise gone unheard, and for everyone to speak up and really help us understand how inequality exists in Ealing. It's a once in a generation opportunity. So I hope we're all going to be able to make the best of it and really, really make that step towards transforming residents' lives. Thank you.
Goodbye.
Thank you all. Thank you, Chair.
Thank you.
Bye-bye.
Thank